Welcome again after the record, and here is a mock discussion number 3 in our mock discussion series. And the first question, my friends, is here a patient who have SLE. Which complication that can happen to the fetus if the mother is positive for anti-Ro or anti-La antibodies? Very simple question. It's well done, everyone. So we do have a problem with the heart block. Yes, so heart block, okay, can happen, and it's adverse pregnancy outcome that include active disease within 6 months prior to conception or during pregnancy, or the first presentation can be during pregnancy. Those who have active lupus, okay, and for example, from the SLE, they have risk of fetal loss 8 to 36%. Those who have antibodies, anti-Ro or anti-La, they have 2% risk of congenital heart block in the fetus. Okay? Yes, Dr. Anwar, exam will come like this. Many, many easy questions in the exam. In the MRCPI exam, I can assure you that 60% of the questions are very easy. Very, very easy. Okay? I can say like 30%, this is for people who studied well, and I'm not saying that is something that is not achievable, not at all, okay? But people who studied well, they can answer the 30% of the questions. 10% of the questions, also to be honest, will depend on your clinical judgment, sometimes can be confusing, especially for people who are not practicing in Ireland. So if you ask me, passing in this exam, the MRCPI written is very easy, okay? And it's a chance that everyone can actually take. But you can't do it with the easy questions only. You can't do it with the recalls only. You have to have baseline knowledge, okay? So if you have the baseline knowledge, you will pass this exam with ease, okay? And I'm sure, inshallah, about this, okay? So my experience with even my colleagues, myself, and my student, over like now 10 years, okay, I have experience with the MRCPI exam. Even I thought that people, they don't have to study for the MRCPI exam after they finish their MRCUG, okay? Just they review the differences in the guideline and go for the exam. This is what I actually believe, okay? But still, you do the effort, inshallah, and you will have your effort paid off very easily. So here we have 48 years old, irregular heavy cycles, we have hot flushes, and the ultrasound show endometrial thickness of 8 millimeter. So my friends, what do you think about this? So my friends who say that the patient, they need hysteroscopy, yes, you are correct that the patient who is 48 years old, okay, and have irregular heavy cycles need to be investigated. And per the NICE guideline, what we will do is taking endometrial sampling and best by the hysteroscopy, okay? Okay, colposcopy is not required at all in this case. Why? Because what is the aim of the colposcopy? Here, my friends, I need to ask you something. What is the main problem of this patient? The hot flushes. Yes, okay. So for this patient, okay, her main complaint is the hot flushes. If we say that the hot flushes is the main complaint, okay, then what do you think the best one that we can advise. And by the way, this is a recall exam question, and I brought it here to this mock discussion for you, everyone, so you will have an example and see, okay, about the quality of the recall question that we have. Okay, so first I would say, yes, the heavy cycles would require taking endometrial sampling. Endometrial what? Sampling. Okay, so I'll tell you how you can solve such a question in the exam. Okay, that's a very important one. Okay, so forget now this version, okay, of this question and see, okay, a complete exam scenario. How can it go? Okay, are you ready, my dear? In the exam, my friends, if I have two problems, okay, the patient presented, like, for example, patient have gastritis and headache, for example, okay, what is her main complaint? Patient have, for example, irregular menstruation, but she have hirsutism that bother, okay, her so much. Another patient who have irregular cycle but have infertility, okay? So I have two problems, right, in the scenario. Which one in the scenario that you need to answer and focus? And sometimes, to be honest, the examiner can be so mean, okay, so tricky, and give you the two problems, and in the option give you two different scenarios or two different options for the same scenario, right? So you don't know which one to go for. Treat the PCOS or treat the irregular cycle or the hirsutism. Treat the irregular cycle or investigate for the irregular cycle or infertility, okay, and so on. So you will have to be focused on what is the patient main complaint in the scenario, okay? So if the patient main complaint in the scenario is the hot flushes, now I need to solve a hair problem, right? And how would I solve the problem of a patient who is still have cycles? She have heavy cycles, okay? So, and even irregular, and she is 48, around menopause. Now she have perimenopausal symptoms in the form of hot flushes. So her complaint of what? Main complaint here is the hot flushes. So what is my answer in this case? Is it tipolone? When to start the tipolone? What is the indication of tipolone in your curriculum? Tipolone is one of the medication that can be used in a patient, right? Who have what? Have what? Which problem? Is that the first line treatment for loss of libido? No, not even the first line treatment. Okay. Can I advise the tipolone for a patient who have breast cancer? No. Okay. Can I advise the tipolone for a patient who doesn't want hormonal? Okay. So do you see here in this scenario any indication for the tipolone? No. So not tipolone. Of course not. Okay. Hysterectomy. Do you think that hysterectomy can help in this case? No. Hysteroscopy. Is the hysteroscopy alone is required here? Patient actually have irregular heavy cycles. Her problem is irregular heavy cycles. Endometrial thickness of a premenopausal woman, HCM, does not necessitate any treatment, right? Itself or any problem. But I would investigate the patient who have irregular heavy cycle, okay, especially if she have any other risk factor, okay, for the endometrial cancer by endometrial sampling using hysteroscopy. You got the point? So I don't care here about the 8 millimeter thickness. Why? Because she's not postmenopausal. The patient still get cycle, okay? So I don't care about the endometrial thickness. Endometrial thickness here is a distractor in the question. So patient pain complaint, hot flashes, I need to solve this complaint. Hysteroscopy has no rule here. Endometrial ablation, no, of course. Right? Combined HRT. Okay. So the combined HRT will be the only suitable answer in this scenario. Right? So whenever you find incomplete scenario in the recalls, don't worry about the incomplete scenarios. Why? Okay, because the patient will have a problem, will have a story. Each word in this problem or in this story makes difference in your choices in the real exam. Okay, so if I have incomplete question, I don't care about it now. I just want to clear the concept, not the question or the recalls. This is one thing. Another scenario or another version, okay, of this scenario is coming here. I'll tell you. This is a patient, still the same, okay? She's complaining of the hot flushes, okay? But in the same time, she have irregular heavy cycle, okay? Not responding to treatment or affecting the quality of her life. What I will do? Yeah, so if the patient have the irregular heavy cycle, not responding to treatment, okay? So the patient, this is her main problem. That's what she tried treatment for. And hot flushes as well, okay? So because she's perimenopausal. And ultrasound show endometrial thickness of 8. Again, I don't care about the endometrial thickness of 8, but I care about that irregular heavy cycle that not responding to what? To treatment. Yes? Okay. Okay, so my dear friends, the irregular heavy cycle that not responding to treatment need to be investigated, right? And the investigation would be before the treatment. Do you agree with me? So let's see options. Can I give, can I start the tripolone in this case? No, 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 no tripolone. Can I go for hysterectomy right away? Since this patient already 48 and she have hot flushes, means that she is near to menopause? No, I can't go hysterectomy first step. Okay? Hysteroscopy and biopsy? Yes, the guidelines say so. Yes? Okay? And endometrial ablation. Can I go for endometrial ablation? Not before investigation, right? So I can go for endometrial ablation in certain cases of heavy menstrual bleeding, but not before diagnosis. Combined HRT has no role here in the problem of irregular cycle not responding to treatment, right? So if the examiner designed the question like this and trying to act tricky, okay, and smart, you will be much smarter in the exam, right, my friends? What you will do in the exam, you know how they play the game, right? You focus on the main complaint in the scenario, right? And then you go to the options and see which one will be most applicable to this scenario, okay? And you go by also logical approach to the management. So usually we do investigation and then we do treatment. Unless he asks clearly what is the best treatment, okay? And by the way, if you have a patient like this and he asks you about treatment, which treatment you will go for? among these options. For a patient, if the patient have irregular heavy cycles, among these options, and she wanted treatment for the irregular heavy cycle, Mirena, yes, is best, but it's not here. Okay, so even if I would choose between treatment and I have a hysterectomy or endometrial ablation, I will go for the ablation before hysterectomy. Okay? So you good that, my friends? So here, for the patient who have heavy menstrual bleeding or irregular bleeding, and she have new onset or worsening of menorrhagia after the age of 45, this is the Irish guideline, the risk of endometrial hyperplasia or carcinoma is higher in this group. Okay, if the patient have also intermenstrual or postcoital bleeding, this is or erratic bleeding in association with menorrhagia is more likely to be associated with either endometrial or cervical pathology such as polyp, hyperplasia, or carcinoma. So what is the investigation? The investigation and management of menorrhagia by the RCPI is simply hysteroscopy. Okay, so in the RCPI, remember, we do the investigation by the hysteroscopy. Hysteroscopy is appropriate when there is regular, unscheduled bleeding or intermenstrual or postcoital bleeding, when ultrasound suggests endometrial polyp, or when endometrial carcinoma is suspected on the ultrasound assessment. It's not mandatory investigation in all women presenting with menorrhagia, as the likelihood of endometrial pathology is very low in younger women. Okay? Patient age, symptom severity, associated symptom, and clinical risk factor should drive the intensity of the investigation. Okay? Clear, everyone? That's good. Okay. We have a midwife reported that she thinks that 2 doctors have more incidence of 3rd and 4th degree prenatal tear during the vaginal delivery. So what will you do? Yes, of course. So making a clinical audit, the clinical audit in this case can actually compare the practice of those doctors to the standard. And if there is a deviation between the practice and standard, in this case, we will see where is the defect, right? So here in the clinical audit cycle, we identify the issue. This is the issue in this scenario, right? That 2 doctors have higher complication rate, and obtain or define a standard. So we can use, for example, the college guideline for the prenatal tear. Collect the data from the patient, right? And this is using of course, the audit performer. And after you take permission from the audit department, then you will compare the performance with the standard, and then you will come to show the result, okay, discuss it, and you will have to suggest the changes. And with the implementation of a change, okay, then this is how we see improvement in the clinical practice. Then you close the audit cycle by re-audit again and see if the levels are still the same or there is improvement really. Okay, so audit question, very easy, alhamdulillah, everyone know it. 2nd degree prenatal tear, which suture material you will use? Yeah, so this is the Vicryl Rapid, yes, and it's a polyglactin 910. Yes, excellent. Okay, so this is a summary slide for the types of the suture that used, okay, in past the question. So they ask about mass closure of anterior abdominal wall, okay, and for the mass closure, you need some tins, right? Something that actually hold for long. So the polydaxinone, okay, will be the suture of choice in this case. Episiotomy you will need the Vicryl Rapid, so the polyglactic 910. For the tubal ligation, so monocryl 10. Laparoscopic surgery, primary port closed by a J-shaped needle and use Vicryl. Okay. Cerclage, it will be by polyester or methylene suture. Bladder, you need the Vicryl, the polyglactin, Vicryl 20 or 30. For perineal tear, remember, polydioxanone, PDS 30 or polyglactin, Vicryl 20. This is for the 3rd degree. Okay. For the rectal mucosa or 4th degree. Rectal mucosa, you don't use the PDS on the rectal mucosa, you use polyglactin or Vicryl 30. Okay. So here, a patient who have HIV with recurrent candidiasis. She is pregnant. So what is the treatment? Recurrent candidiasis, very easy. Can I give fluconazole in the pregnancy? No, 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 I can't. So what I can use instead? I can use the clotrimazole. Yes, clotrimazole pessaries, okay, will be used in the pregnancy safely. And the regimen for the recurrent vulvovaginal candidiasis in the pregnancy, as you can see here in the reference, this is induction, okay, so starting by the induction phase, and it is pessary of 500 mg per vagina, one night for 10 to 14 nights according to response, and the maintenance doses is the clotrimazole pessary, same 500, but it will be once per week. Okay, friends? So this is for the recurrent cases. Now, next question. Patient with type 1 von Willebrand disease wishing to conceive but trouble with menorrhagia. What is the best management? She had a trouble with menorrhagia, but this menorrhagia is due to the von Willebrand disease type 1. So what you can give in this case? Okay, guys, hold on. When to give the patient the desmopressin? When I will give the patient the desmopressin? Desmopressin will not be taken as a long term, but it can be very useful during procedures, right? Like, for example, if the patient have labor operation, right? After you check for what? For the factor level. So factor level need optimization before procedures. Then in this case, I would, according to the factor level, I would discuss the desmopressin, okay, with the hematologist. But is that the case now? No. No, this is not the case. So what is the problem in this case? She had menorrhagia. So which medication can help menorrhagia in patient with type 1 von Willebrand disease? Tranexamic acid. Okay? So tranexamic acid, my friends, is those patients' best friends. Okay? And mefenamic acid as well. Right? So basically, tranexamic acid will be very useful for those patients. We even prescribe the tranexamic acid to the patient after delivery, right? For 5 days after delivery, is that correct? So this is to reduce the risk of secondary postpartum hemorrhage. So tranexamic acid in this case will be useful, okay? Plus the mefenamic, plus Romaines and mefenamic acid, okay? It will reduce the blood flow in the menorrhagia cases. And by the way, we can give it to any case of menorrhagia, right? Not only those who have von Willebrand disease. This is here for the patient who is pregnant. So remember, question about menorrhagia, but here, this is the guideline. This is from the guideline, the RCUG guideline, which is the source for the MRCPI. This is pregnancy and antenatal care advices. When we go for the desmopressin, okay, then we can go before procedures, right? And when the factor level is actually below 0.5. right? Women have severe pain in the pelvic girdle and difficulty in turning in the bed as well. So what to do? The pelvic girdle pain. Yes, well done. Well done. So it is well done, everyone. It's the physiotherapy and counseling, right? Yes, well done. So changing in the daily activity, doing special exercise, the physiotherapist will help in this regard, okay, and will teach the patient suitable exercise, okay, to help her symptoms, okay. They might also advise some pelt, supportive pelts, okay, which can provide relief. Here, my friend, if there is also problem, my dear, if there is also problem, okay, but a pain is starting with, okay, which is, by the way, it's very common, okay, pain is starting with simply the physiotherapy and the exercises, okay, it will relieve the stiffness, especially when he tell you that the patient have a problem, okay, with turning around in bed. So here we have a patient with FSH, vasomotor symptoms, using combined HRT. She's asking for contraception. So the patient is 48. She had vasomotor symptoms, and she's on combined HRT. And she wants contraception with the HRT. So what can I advise? Look, my friends, for the patient who have vasomotor symptoms, okay, and she is still, okay, new to the menopause, okay, look like this patient have checked her FSH, means that this patient may be younger, okay, than the age of 48, right? But anyway, we will deal with the situation as it is, okay? So for the patient who's using the combined HRT, okay, and she is a perimenopause or she is a POF, okay? Like, let's say that she is below the age of 40, okay, or she is around the age of the menopause, around the natural age of the menopause, and she start to have a vasomotor symptoms, she's still need contraception and HRT. Our patient combined HRT. What I can do? Do you think that adding progesterone in the form of POP, my dear, will relieve the vasomotor symptoms or actually increase? What do you think? Okay, so it's not adding progesterone. Adding progesterone will not cause any relief at all. Okay, so I can't use the Mirena along with combined HRT. Because what is the regimen of the Mirena if the patient wants the Mirena and the HRT? We give estrogen as patch or something plus Mirena. Okay, but we don't give oral or give combined HRT plus Mirena. No, we never do this. Implant, no. Implant is not for vasomotor. Too much actually progesterone. POP, no. So what is the answer now by exclusion? It's switched to COC, okay? So the COC can be used as switch, okay? Especially if the patient is younger or the patient is around the perimenopause, okay? It will be used only, my dear, for a short period, okay? So it's not contraindicated to use at the age of 40. But yes, it's not the best choice. But the patient, she have contra, she have a problem with the vasomotor symptom. She used a combined HRT, and we are not sure, okay, what is the problem, right? For a patient who have premature ovarian insufficiency, okay, she can use either the hormonal replacement therapy or the COC, right? Can be used as hormone replacement therapy, okay? But the good thing about the HRT is that it more closely mimics the natural hormone level, okay? The COC could be considered as a common and convenient choice, especially for those needing contraception, okay? For the progesterone, okay? Sorry, for the patient who have contraception requirement and HRT in the same time, we can give only COC, okay? But HRT, it has very good benefits in terms of the cardiovascular, right? And the bone health. So if I wanted to give this patient option of contraception and HRT in the same time, okay? What can I give? Look, my friend, I have for the contraception choice, not for the vasomotor choice, okay? I have either estrogen plus Mirena. This will be very helpful, okay? Especially if I give the natural type of the estrogen. So I can use the Mirena, but not with the combined. The Mirena will be used with the estrogen only, okay? HRT. Or I can give for COC, right? This is the contraception option, not the vasomotor option. You got the point, guys? So Mirena will work here for the contraception and for endometrial protection, and the estrogen, okay, will work for the vasomotor symptom. This is the best combination. Okay, so estrogen plus Mirena. This is the best. But do I have this in the option? I have only Mirena. Okay, so if he give me in the exam only Mirena, I can't use Mirena with combined HRT unless he mentioned Mirena plus estrogen. So it will be yes. If she had estrogen patch, yes, of course. Look, my dear Dr. Aisha, you must give with the estrogen patch, you have to add a source of progesterone for endometrial protection if the patient have uterus, right? So what is the best? It's Mirena. So Mirena will work as endometrial protection and as a contraception in this case, Dr. Aisha. Okay? Dr. Farida, what does the patient want? What does the patient want in this scenario? The patient want was patient complain. The contraception, yes, well done. Okay, patient to complain is the contraception. Now I wanted to give her a type of contraception that it in the same time help, okay, for the vasomotor symptoms and for this high FSH. So what does the guideline says? The guideline says that COC can be a good option, right? HRT is best for the bone and cardiovascular health protection, but COC for contraception, right? You got the point? Okay, so any patient who is menopausal, perimenopausal, premature ovarian insufficiency, and she comes to you, she wants both contraception plus replacement. Okay, I'm not saying here replacement only. I'm saying contraception plus replacement. What you will give? You have to choose between COC or estrogen plus Mirena, not Mirena alone. Okay? What if I added an option for you, my friends, here? Think about the box, outside the box. And they told you that IUCD is in this case, what you will do? Okay, so if the patient have IUCD in place, I will be so happy and she will take whatever HRT she want, right? So this is a good option. And this is would be very safe one. So you agree, everyone? May I ask you, my friend, if the patient is taking HRT, combined HRT, this patient need extra contraception or no need? Let me go back to the very basic. Need or no need? Yes, she need. Yes, very important. Why? Because HRT can suppress ovulation in less than half of this patient, around 40% only. Okay, so the patient, if she is still keen, okay, to avoid pregnancy, please give her either COC or Mirena plus estrogen. I hope it's clear, everyone. So a 48-year-old patient with FSH, okay? Yes, so we're just saying about this question. FSH 42, vasomotor symptoms using combined HRT for asking for contraception. Now, what is the answer? Answer will be IUD. Yes. Patient with dyspareunia, she have some problem with all partners. Okay, so her problem with all partners. Okay, difficulty in putting tampons. What the form of the treatment you will advise? Psychosexual therapy. Yes, yes, yes. Psychosexual counseling is the best. Okay, so other things that the patient can use, the relaxation technique or pelvic floor exercise. And actually pelvic floor exercise in this patient who have vaginismus or she have dyspareunia at the time of sexual activity, okay, which we call a provoked vulvodynia as well. They will benefit from pelvic floor muscle exercise because the squeeze and relaxing exercise will help gain control over the vaginal muscles. Also sensate focus, okay? So this is for relaxation during sex, okay? And vaginal trainers, right? So those are the possible options for this patient. Old lady with guarding and rebound, okay? And the scan show 10 cm complex cyst. What is the management? So the patient have symptoms and she have complex cyst, 10 cm, big one. Yeah, this patient will need a staging laparotomy, right? Right? So, of course, not laparoscopy at all. It's only midline laparotomy for a staging laparotomy. Yes, exactly. Well done. After delivery, patient had postpartum hemorrhage, delayed placental delivery, uterus not palpable. There is a bulge in the vagina. So how would you treat her? What is this problem, my friends? Inversion, yes, well done. So the hydrostatic and manual reduction of the uterus, well done, everyone. Okay, and these are the notes from the Irish guideline regarding the uterine inversion, okay, which can happen in cases of adherent placenta or can happen from inexperienced midwife during the cord retraction, okay. Microinvasion of the cervix, 4 by 2 millimeter. Now, 11 weeks of pregnancy, what will be the management? Which stage is this? Hello, hello. Which stage? 1, 1A, 1B, 1C? What do you think? 1A. Yes. Okay. It's a millimeter, my dear. This is millimeter, Dr. Hayat. Okay. So what is the management? What is the management of cervical cancer, microinvasive disease during pregnancy? So why cesarean section at 32? Why cesarean section at 32? Give me a reason, please. No, so I don't need this 32 weeks section and chemo. No, I don't need this. 38 cesarean section is all the patient need cesarean section if they are having microinvasion and treated by conization? No. Right? Okay. Terminate pregnancy and hysterectomy? No. So the only option that this patient can safely deliver vaginally, right? After treatment, of course, right? Yes, he didn't mention about the treatment in this case, but he's just asking about the management for the delivery management. Okay, so this patient can go safely for a normal vaginal delivery, right? And if he asked me about the options of the management for this patient, okay, I only have one option. The case who have microinvasive disease, actually can be very good, you know, early diagnosis because the risk of the vascular invasion is very low. So you don't need to do lymphadenectomy, right? So still local treatment can apply. Okay. Yes, conization. Yes. Okay. So treatment of stage 1A1, microinvasive without lymphovascular invasion. So the treatment will be conization. Okay. Women should be encouraged and support the aim for vaginal birth if there is no obstetric contraindication. Okay. So my dear Dr. Anwar, so what do you think about the exam now? Still easy, right? But some questions are there for people who really studied because they have to differentiate between people who make an effort and people who didn't make an effort, right? So this is, yes, to be fair, to be honest. Okay. So, and by the way, I think also that the MRCPI exam is very fair exam for obstetrician and gynecologist. Okay. And it seemed like an exam for obstetrician and gynecologist. You know, MRCUG exam, it's a little bit, okay, exam about being a consultant. They ask you for decision making, for management, for the system. They ask you legal problems, clinical governance, right? They ask you many things, okay? Not only the specialty of the obstetric and gynecology, but the MRCPI exam is a very good exam for people who are preparing themselves to be specialists in obs and gyn, right? If you have knowledge, you will do it. So primary with history of recurrent herpes at the third trimester, concerned about transferring infection to baby. Of course, recurrent herpes have low risk from 0 to 3% risk of transmission, correct? So which advice you will give? Okay, can I just go to reassure that risk is very low, don't give a cyclovir? Can somebody say this? So what do you think, Dr. Susan? What do you think, Dr. Jubair? No, we need to do. Yes, every guideline want suppressive dose. Suppressive dose of what? Of acyclovir. Okay? So when you will start the suppressive dose? 32, 34, 36, 38. Choose one, please. So the cyclovir that will be used in the 3rd trimester. Okay? What is the update of the PASH guideline? Update in the PASH guideline is 32. Not in HIV only. 32 for everyone. Okay? The update in the PASH guideline is 32 for everyone. Okay? HIV, no HIV. It's now in the PASH guideline for everyone. Okay? So what is the doses? It could be the cyclovir 400 3 times, or valacyclovir, okay, 500 mg 2 times per day. Okay? Okay. So I'll send you the update, Dr. Mahush, after we finish, okay? Which of the following is not feature of Turner syndrome? Not. Okay? And this is very recent exam question. Asking about what is the feature, not a feature of Turner, what is not a feature of Down. Okay? You know that congenital malformation is very important in the MRCPI exam. Okay? And there is a guideline for congenital anomalies. So please be careful. You have to make like a gallery, okay, for the genetic problems. Okay? Prepare yourself because they will ask you one question from here, one question from there. Okay? So microcephaly, not atypical features of Turner. 55-year-old. She is on combined HRT for 2 years. Come with vaginal bleeding for 3 months. Ultrasound is normal. So what you will do? She's on combined HRT. How many months she is there? Is 2 years. And the vaginal bleeding is not just one episode. It was continuous for 3 months. Ultrasound is normal. So what I need to do? Look, my friend, if the ultrasound is normal, what is the meaning of normal? I need one of you, my friends, to tell me, okay? For the patient who is postmenopausal, what is the meaning of normal ultrasound? If she is on a sequential or if she is on continuous. Because it's make different, right? If the patient on continuous combined HRT, which is more likely in this scenario as she is already 55, okay, means that ultrasound, if the endometrial thickness less than 4, right? From 4 or above, what I will do? If less than 4, I can do something, okay? Changing dose, trying modifying dose, okay? Okay. If I have 4 or above, and the patient was in continuous combined endometrial biopsy or hysteroscopy, okay? Okay. If the patient is using sequential HRT, then my cutoff is 7, okay? Below 7, it's normal. 7 or more, need endometrial biopsy or hysteroscopy. Okay, my friends? So if there is unscheduled bleeding and ultrasound normal, what I can do? I can modify, right? Okay. Okay. So what about if the patient have a recurrent bleeding or persistent bleeding? Even after you try, then recurrent or persistent, what you will do? You will go for, again, hysteroscopy and biopsy, okay? Okay, so looks like somebody need to revise the guideline of unscheduled bleeding on HRT, okay? It was last year release, I think last year, right? And it's very important for the exams. So my friends, okay, continuous combined, again, we use 4, sequential, we use 7, okay? Do you depend on the TUG article, the older TUG article? In a study, no. If you're depending on the TUG article, the older TUG article in your study for unscheduled bleeding, please now go for the guideline. Here, BMI 40, and she's for 8 weeks with urine retention. What is the cause? This is something common from the clinical practice, okay? That retroverted uterus, okay, can cause urine retention, right? Okay. A 34-year-old with positive BRCA mutation and a strong family history of breast cancer. She had no kids. What is the most appropriate risk reduction management? She had BRCA. BRCA need bilateral sublingual oophorectomy or hysterectomy as well. No need for the hysterectomy, right? Okay. So if I speak about Lynch, so what is the risk reduction strategy? Yes, it will be both. Yes, it will be both. Okay. Okay, Dr. Mahwish, if she had or doesn't have kids, okay, is not your problem. You know what is your problem? Your problem is desire of fertility. Okay, he's speaking about Western countries, right? So this exam is actually coming from Ireland, right? So you do care about having kids or not, or you do care about fertility desire. Yes, okay, after family complete, did I say now? Did I say today? Do I have another option? It's just asking you, my dear, about what is the most appropriate risk reduction management for a patient who had BRCA mutation. So this patient will need, it's a BRCA1, right? 44% of ovarian cancer. It will be bilateral salpingo-oophorectomy, right? Do we have any better answer for this? No better answer, right? But if the patient, for a patient who have, yes, Dr. Aisha, of course. If I have a patient with BRCA1 mutation, the best reduction surgery, risk reduction surgery, will be the bilateral salpingo-oophorectomy, and this will be by laparoscopic approach, not abdominal, not open. Okay? The option number 1 says salpingectomy, which is no. Okay? Oophorectomy, no. I need to remove both because there is risk of tumor comes from the tubes, right? Total abdominal hysterectomy, this is not for BRCA. This is for Lynch, okay? And here, total abdominal hysterectomy and bilateral salpingectomy, why? No, there is no such option. Okay, my dear? So only suitable answer is bilateral salpingo-oophorectomy. Do you have any problem, my friends, in this question? Is it clear? Is it clear? Okay, good. Yes, well done. Okay. Yes. Okay. So patient doesn't have children now. It's not my problem, right? Unless he's discussing something like how to keep, for example, freezing eggs, okay, cryopreservation. Okay, so something like this, I can think about it. She doesn't have a partner now. She wanted to keep herself safe. She doesn't want this option, but she wants surveillance. Okay, which is not the question that we have here now, right? Because there are other options if the patient wanted to retain her fertility, right? He didn't mention anything here. Having no kids is not your problem, right? Since you only have 5 options to choose between. Okay. So my friends, thank you very much. We have finished our mock discussion today, and hopefully that you find it useful somehow. Hopefully, inshallah. Now I have to, yes, I have to take a break. Okay. Then I will start another round with your friends in the MRCPI okay, in our group, the January 2026 exam group. So I know that many of you, mashallah, are planning for double certificate. So if you are planning for the MRCUG part 2, please go have a break and then come back after 15 minutes. We will start. Okay, thank you very much, my friends.